This presentation covers the concept of comfort from Module 6. Objectives in this concept include discussing the principles of comfort in regard to emotional, spiritual, psychological, and physical aspects, discussing factors relating to clients' experience of pain and rest throughout the lifespan and with cultural consideration, discuss various developmentally appropriate pain assessment tools to evaluate pain status in patients across the lifespan, describe the nurse's role in collaborative strategies for pain management and promotion of rest through pharmacological and non-pharmacological therapies, and describe potential consequences of sleep deprivation as experienced by patients, nursing students, and staff. Okay, so let's first talk about the normal presentation of comfort. So in a physiology review, let's talk quickly about Maslow's hierarchy of needs, right? So comfort, first the individual's most worried about air, right? That makes sense. Food, water, safety, comfort. So comfort is in there, and it's going to be more concerned with comfort before they get to niceties such as, a car and a job and things like that. So comfort does fall in Maslow's hierarchy of needs. We need to understand as nurses what is normal for that patient. So what is comfortable or promotes comfort for one individual may not for another, and it's important for us to recognize that. Comfort is objective. It is a sympathetic nervous system response. It is defined by the presence or absence of pain, the degree of sleep and rest the individual is experiencing, a balance of nutrition and fluids, and also sense of perception of heat, cold, odor, or noise. Okay, so there's 5 common sources of discomfort. There are others, but these are common causes: pain, end-of-life experience, fatigue, fibromyalgia, and sleep and rest disorders. So let's talk about them individually and then how they manifest themselves in clients. So pain is an unpleasant sensory and emotional experience. It's associated with actual or potential tissue damage. Pain is described in terms of damage. Patients can only describe pain subjectively. They can only describe it from their point of view. Pain plays a protective role because it lets an individual know that they should stop doing something, and it also can be a warning of a problem, impending problem. And pain also, we need to remember as nurses, is the 5th vital sign. Pain can be described and assessed in terms of duration, how long it's been going on, or how long it lasts in an episode. Intensity, we can rate that on a scale of 0 to 10 for adults who can appropriately use the numeric pain scale. Etiology, so where it's coming from, where it is, what seems to be causing it. And then location, where in the body it's located. And the duration of pain is the difference between acute and chronic pain. So how long it lasts in an episode, so that would be more acute. And then a pain that is consistent and persistent would be associated with chronic pain. Okay, so let's talk about acute pain. Acute pain often has a sudden onset and lasts only through the recovery period. So it would not be extenuating past the time of recovery of an illness or injury. So, which we typically look at, and it depends on the illness or the injury, from 30 days to 6 months. Chronic pain is defined as pain that lasts longer than 6 months, that it's consistent and persistent. It persists beyond the expected healing period. And we need to remember, which is part of our role and responsibility, is that clients have the right to adequate assessment of pain and management of their pain. Okay, so end-of-life care, we're going to talk about that in the next couple of weeks here at the end of this course. End-of-life care requires physical, mental, and emotional comfort for clients and their families. It also requires that we provide the client with social support to the extent that we can, but we need to provide them the opportunity to communicate and have their social circle as part of their support at the end of life. End-of-life care is given to those with and dying of advanced illness. And we need to remember, and we'll talk about this, and you'll see different examples of this, that nurses have a great impact in end-of-life care on patients' daily activities, providing patients and their families education and information, providing emotional and spiritual support, and then also guiding families through the process that help them make ethical decisions for their loved ones. Okay, so fatigue, let's just talk about like being tired, okay? So fatigue is defined as a lack of energy and motivation. Acute fatigue would be considered what is normal tiredness, normal level of being tired associated with a single event. So the symptoms resolve quickly. So we've maybe had a busy day, we've run, we've gone to the gym. So that fatigue would be normal, right, associated with and surrounding a single event. Chronic fatigue, however, is more intense and lasts longer. Symptoms do not resolve quickly. The chronic fatigue may be exacerbated by physical and mental activity. Chronic fatigue is commonly caused by long-term illness or even associated with medications that cause sleepiness, somnolence, just kind of lack of energy and motivation, such as chemotherapy medications. There is a syndrome called chronic fatigue syndrome. It's chronic fatigue that lasts longer than 6 months, accompanied by muscle and or joint pain, headaches, and sleep and memory problems. Okay, sleep and rest disorders. So sleep is a basic human need. We all know that, right? Sleep allows the body to enter a phase of restoration. So this is where the body regenerates. So muscles repair. We are able to bodily functions take place while we are asleep. So sleep is essential. Sleep deprivation hinders daily functioning, adversely affects health, and is linked to increased risk for motor vehicle crashes, right? Which makes sense because if we're too sleepy, because we have been sleep deprived or we are sleep deprived, then we're more likely to be less attentive when behind the wheel, and obviously that's a problem. The Institute of Medicine recommended more study of sleep disorders and awareness of problems caused by sleep loss and sleep disturbances. They've become aware that it's a problem, and it's a problem in our country where we're working longer hours, we're doing more, trying to pack more into a day, we're less likely to rest and restore the way that we should. Some common sleep disorders are sleep loss. So we're just not sleeping, and that could be things like we're new moms, we have small children who maybe aren't sleeping well through the night. Perhaps we have a spouse who doesn't sleep well, and they, unknowingly or unintentionally cause us to be awake. Sleep apnea. So individuals stop breathing while they're sleeping, which causes the body to awaken itself in an effort to increase oxygen intake. Insomnia. So some individuals have difficulty falling asleep. Some individuals have difficulty staying asleep. So there are different types of insomnias. Narcolepsy is a condition that causes individuals to fall asleep at unintended times. And then also restless leg syndrome is actually a neurological disorder that causes restlessness in the legs, which keep people awake because it's so intrusive and so disruptive. Individuals can't. It wakes them up to have to move their legs. So, and you'll see that in the hospital. Individuals are medicated for it, and we try to promote sleep through the use of medication, calming the restless legs. Okay, there are some considerations and non-modifiable risk factors associated with rest and comfort. We have found through study that genetics affect the susceptibility of individuals to diseases associated with discomfort. Some genetic disorders directly affect an individual's ability to perceive pain. Some genetic mutations are associated with sleep disorders, and then many psychiatric disorders also have genetic components. So what can we do as nurses and those in the healthcare profession to promote comfort, promote rest, and decrease pain? So teaching the client lifestyle changes that help to decrease pain, decrease depression, decrease fatigue would be helpful to these individuals feeling better, have a greater sense of well-being. Okay, we need to teach concepts such as sleep hygiene, psychosocial well-being, and also relaxation therapy. Okay, so sleep hygiene includes things like a bedtime routine. So maybe we take a bath or a shower, or we turn off TV, we turn off technological devices that decrease the amount of blue light. Psychosocial well-being, so we have a good social support. We are social at least some of the time with other individuals. We're feeling well. Okay, and then also relaxation therapy can be a technique to use to decrease pain and also increase comfort and rest. We also can talk to individuals about personal preferences, things that they do prefer. Maybe some clients would be open to relaxation therapy techniques where others would not. So personal preferences do come into play when we talk to individuals about how to decrease pain, decrease depression, increase sleep and comfort. Lifestyle habits that we can also impact with education could be nutrition. So eating foods that are, balanced nutritionally, and also avoiding heavy meals in the evening and a balanced diet. So yes, a bedtime snack, but that's not 3 bowls of ice cream and 3 sodas. Also decreasing and stopping use of tobacco, alcohol, and also illicit drugs. And then also we can talk to individuals about their occupation. Are these things causing fatigue? Are they causing increased stress? Are they causing a decrease in the amount of time that we have available to rest and sleep? And then some conditions can be exacerbated by the fact that we're not resting, we're not sleeping, because we're doing specific things at work. Maybe we have a very physical job that causes us to have increased pain and things like that. So definitely occupation, and then also recreational activities. We can take a look at those to potentially modify to help promote sleep, promote comfort, decrease pain and fatigue. Okay, so let's start with the nursing process. Assessment. Okay, the nursing assessment should explore the patient's level of discomfort. Okay, and that could be anything from a minor discomfort to severe pain. We also need to assess the degree to which discomfort is affecting the patient's life. Chronic pain can be very debilitating. Even a patient who is accustomed to that level of discomfort, their life can still be affected negatively. Also, observation of the patient and the patient interview. We would observe obvious signs of discomfort, grimacing, wincing, close their eyes real tight, tenseness in the body. Okay, we need to discuss the current problem. So we need to talk about the patient complaints related to the discomfort associated with the current problem. Also use the numeric pain scale if the patient can appropriately use a numeric pain scale to gauge their pain level. And also we need to talk about how the current problem affects the activities of daily living, affects their sleep, affects their motivation, and also how long has this been going on? How long have these things been affected by the current problem? Also the patient history. Does the patient have a history of chronic pain or conditions that have the potential for causing chronic pain? And then also, what is their lifestyle? Are you resting? What is your activity level? And then what do you do for work? Do you have an occupation that potentially exacerbates pain conditions or decreases the amount of rest and sleep that you get? Okay, so further with the nursing assessment is the physical examination. So we need to be mindful that the nursing assessment should be guided by the patient's age, the ethnicity, and we've talked about that before. Some cultures are not comfortable with a disrobed assessment, so we need to take that into consideration. And also the severity of the discomfort. We need to make sure that we're assessing all of the elements of that painful area. So is it internal, external, is it at a joint? And again, using the pain scale to allow the patient to indicate their severity of pain. Also in physical examination and partly observation, we would look at posture, gait, I mentioned grimacing before, and verbal complaints. What does the patient say about their discomfort? And then also guarding. We need to focus on a few different things. First of all, the onset. When did this start? Do we know the cause? Did it happen, surrounding a specific injury or event? How long has it been going on? Relieving factors, does anything make it better or worse? And then worsening, which would be the factors that create more discomfort. Okay, so this is not necessarily specifically related to nursing assessment, but you need to know that these things are out there for diagnosing different types of issues. So we might be able to find causes of pain or fatigue on x-ray, using blood tests, and also lack of sleep and rest. We might be able to detect the cause with the use of a sleep study, which would typically illuminate sleep apnea. Okay, so let's look at the independent interventions. Okay, so these are independent. These are going to be nursing interventions independent of other disciplines. They are directly aimed at identifying the source of discomfort and focusing on that to alleviate the discomfort. So pain relief is a priority. Okay, if the cause is not identified, interventions may focus on the non-pharmacologic measures. So first of all, by identifying the cause, the source, I mean something, for example, if there's a fracture, so it would be important to identify that, right? Because if we can focus on the fracture and use treatment measures for that, which would be physician related, fix that piece, and then the pain, at least in part, would be alleviated, and then we could go on to either pharmacologic or non-pharmacologic measures after that. So that's what I mean by identifying the source. Can we immediately take away the source of this discomfort? Okay, and then if we can't do that, let's look at things to decrease the pain and promote comfort. So heat or cold compresses. We might try to distracting the patient. That depends. A lot of factors come into that. Sometimes that works with kids. It kind of depends how severe the pain is. Sometimes we can use TV or, a technological device, so a video game or iPad, something of that nature. We can, again, talk about sleep hygiene if pain is preventing the patient from sleeping. Repatterned thinking, so can we reframe this pain? Can we get them into a pattern where we can have them start at the beginning? Can we identify the source of the pain? Can we address it with either a pharmacologic or non-pharmacologic pain relief method? And we can get them into that pattern also, so that when they go home, especially, well, both in acute and chronic pain situations. So acutely, we need to let them know that we probably have identified the source. It could be related to surgery or injury, something of that nature. And then here's what we need to do going forward, and try to get into a better routine of pain management. And then also chronically the same way. When does the pain begin? Is it present all the time? What makes it better or worse? And try to get them into a process that helps them keep their pain under control. And then also introduce relaxation therapy if that's appropriate and the client is open to that. I spoke a little bit about sleep hygiene earlier. This is a little bit more detailed. Sleep hygiene is a variety of sleep practices that help individuals attain good quality sleep. So those things would include maintaining a regular sleep-wake pattern. Okay, so go to bed about the same time every evening and then wake at the same time in the morning. Performing bedtime rituals, as I mentioned earlier, providing restful environment. So that means, TV's off, lights are off, it's quiet, and the room temperature is good, so the patient is neither too hot nor too cold. Promote comfort and relaxation, whatever that means. That could be positioning. That could mean, a pillow under the knees. It could mean, whatever that means for that patient, whatever comfort and relaxation means for that individual. We need to be mindful in the hospital that patients typically don't get a lot of rest there. I know it sounds strange, but we need to be mindful that we could and need to, whenever possible, to schedule hospital activities around the patient's sleep pattern. So if it's necessary to keep the patient alive, for example, of course I might need to interrupt your sleep. However, if it's just to come in and maybe do vital signs, maybe I could delay it a little bit until next time the patient's awake or something of that nature, so that it interrupts sleep and rest as little as possible. And then also minimizing environmental stimuli in the hospital. So night shift typically will turn the lights down. They will turn lights off in the patient's room. They will keep the door closed to keep the noise down for the patient in the room. So there are things that we can do. We need to be mindful of that. Just because we're awake at night in the hospital doesn't mean that the patients want to be awake at night in the hospital. Psychosocial well-being, we need to, laughter is always important, even in, very grave situations. It's important as much as possible to keep a positive attitude. We need to encourage participation in enjoyable activities, and that's whatever that is for the patient. It might not be our definition of an enjoyable activity, but it's important that we recognize that it could be for them. Interactions, as I said earlier, with family and friends, and potentially support groups. These slides, just as I said earlier, just kind of go more specifically into the details of these different types of interventions. Relaxation therapy can help reduce stress, induce sleep, reduce pain, and calm emotions. There are 4 main categories of relaxation therapy, and sometimes they're combined for use with one another. They include breathing exercises, muscle relaxation, imagery, or commonly called guided imagery. Sometimes we use it with a like a voice playing or something that's guided toward relaxation, and then also movement techniques that can promote relaxation of muscles or body parts, joints, etc. Other forms of relaxation therapy include massage, acupuncture, meditation, and biofeedback. Massage and acupuncture are not typically offered in the hospital by staff or hospital personnel, but if the patient engages in meditation, certainly encourage that. And then also, if they're accustomed to using biofeedback as a method of relaxation, definitely encourage that they continue to do that if that's helping them manage sleep, rest, pain, discomfort, etc. Okay, so this is comfort and pain focused, but the pharmacologic methods, which would be part of collaborative interventions, right? Because we talked about this before, the physician's going to order it, pharmacy is going to enter it into the computer as an active order for dispensing to the patient, and then the nurse is going to administer the medication to the patient. So pharmacologic interventions include non-opioid pain medications, non-steroidal anti-inflammatory drugs or NSAIDs, opioid pain medications, and then possibly hypnotics or sedatives. Okay, so these are collaborative interventions also. So these are not going to be things that are provided by the nurse exclusively or independently from a provider of some type, but non-pharmacologic pain or interventions for pain, discomfort, promoting sleep and rest include acupuncture, herbal supplements, biofield therapy, exercise programs, physical therapy, pain clinics, aquatic therapy, electronic health or mobile health applications, and then also medical marijuana. So just be mindful that these things are out there. We could assist with some of these therapies in terms of we might be able to make sure that the patient has, if they're going to use a mobile health app, their phone is charged, it's within reach. We're providing them transportation to maybe aquatic therapy in the hospital, or maybe physical therapy comes to their room, and you're ensuring that the patient is ready to participate in physical therapy. They have the appropriate socks or shoes on, their gowns on, and things like that. But as far as like providing acupuncture, we don't do that. Biofield therapy, that's not something we provide. The patient may have engaged in that in the past, and maybe a family member helps them with that. It's not something we're trained to do, so we don't do that. Pain clinics, chronic pain management would be managed on an outpatient basis. And then of course medical marijuana is not something that we engage in dispensing of in the hospital. Okay, so Across the lifespan, as you can imagine, there would be different responses to discomfort, pain. There would be different responses to the lack of sleep. So we need to talk about that and just be mindful that across the lifespan, individuals will react differently to those different factors. So infants and toddlers, they most often verbalize or vocalize discomfort by crying. We need to elicit parents' descriptions of how the infant manifests pain. So they know their baby, their child. So when your infant's having an earache or a bellyache, how do they most often act, so that we're able to identify that and know that it's a pain response. Sometimes discomfort and pain can be related to milk components. So they may have a dairy allergy, or could have allergy really to a lot of different things that could cause GI upset and things like that. But we don't know, because baby can't tell us. They don't know. We don't know that it just upsets their stomach, whereas adults may be able to verbalize that much better. Often we can comfort infants and toddlers by holding them or rocking them, murmuring soothing, quiet words, or rubbing and patting the torso or the extremities. And many pain medications have no dosing instructions for children under 2 years. So pain medication can be very tricky, both at home, if mom and dad are going to try to use something over the counter at home, or specifically in the hospital. So a lot of medications are not appropriate for use in children under 2. So we need to look to the non-pharmacologic interventions as definitely important in this age group. Children, we can more involve them in describing the discomfort. Tell me, does it ache? Is it just kind of sore? Does it burn, like you're being burned by something? So we might be able to get a little bit more information from them because they're verbal. Also, at this point, parents would still be able to probably convey to you what the child's typical discomfort behaviors are. We need to talk to the children always, regardless of the age, but this age group, children typically understand a little bit better about what you are going to do to them. Explain it in a way that they can understand, that may help decrease their anxiety. Demonstrate procedure on a parent if possible. So, and that lets them see what you're going to do, that, what the possible reaction might be by the parent, as far as, oh, it didn't hurt, mom or dad, so I can understand that it probably won't hurt me either. We can comfort children by hugging them, holding their hands, or giving them a treat. Okay, we're going to move on to adolescents. We need to remember that we can interact with them as adults and not children. So we shouldn't be treating them as if they're children. And we need to remember that because they're trying to find their independence, they may reject an offer of comfort. Adults, we need to remember that we need to listen to them carefully. Okay, listening is an important part of a nurse-client interaction. Adults may also find comfort in knowledge, so just providing them some education may help alleviate some fears and help them understand the process, and then how they can participate, and then also work towards alleviating discomfort, promoting sleep and rest, things of that nature. Older adults. Older adults are more likely to have chronic conditions which can cause chronic pain. We need to make sure that we're providing a safe, comfortable environment for regular appointments. So if you are working in a clinic or outpatient area, we need to make it a welcoming environment. Older adults, just because they're older and understand things doesn't mean that they want to come to the doctor any more than children do. We need to be sure that we're explaining the procedure that they're having while they're there, if there is a procedure, and then also reviewing medications at each visit, just to reinforce that education and make sure that they're taking it appropriately as it was prescribed. We need to also provide written instructions and explanations whenever possible, so that they can have a written version with them and have them those things available for review at home with them. You might use highlighting, some charting electronic medical record systems allow a larger font. So that might be an option for older adults. And then also we need to provide assistance with movement as needed. So this is whether it's in the hospital, out of the hospital. These individuals that have chronic conditions may experience, chronic discomfort regularly. So any assistance that we can provide to promote comfort and decrease pain is definitely warranted. Okay, let's talk about pregnant women. Pregnant women, there's a lot of things that are happening to them and going to happen to them during childbirth and the immediate postpartum period that are not comfortable, not necessarily pleasant. So they may be anxious, okay, especially if they've never gone through pregnancy and childbirth before. So we need to just keep that in mind, okay? We need to take the time to explain what they can expect and to answer their questions, which in some clients is a lot of questions and in others not very many questions, okay? We need to provide tips on self-care, physical activity, and sleeping positions that will ease discomfort. So these women are, especially toward the end of pregnancy, uncomfortable, not sleeping well, anxious. They may be even having chronic pain from other conditions that they had prior to pregnancy, or even some conditions can be exacerbated or initiated by pregnancy, for sciatica, for example, that's extremely uncomfortable to even extremely painful. And so we can help just get them through this period, let them know that this is, as a result of pregnancy or being made worse by pregnancy, and do whatever we can to just give them those tips that will help them be more comfortable. We need to definitely encourage adequate nutrition, adequate hydration, and adequate sleep and rest. They're growing another human being, so they need all of these things. Dehydration later in pregnancy can actually initiate labor, and we don't want that before it's time. So we need to make sure that moms understand, like, you need sleep, you need rest, you need lots of fluids, and you need appropriate nutrition. Okay, so this is a end of life lifespan consideration. We need to ensure that we're providing adequate pain relief with pharmacologic agents as ordered. We also need to provide pain relief with non-pharmacologic agents, okay, if we can administer those types of things independently. So that's often going to be things like positioning, could be heat or a cool pack. It depends on what's going on with that specific patient. We need to offer to arrange a visit from a spiritual leader and or loved ones when it's appropriate or if the patient requests. We need to facilitate referrals to grief counseling for the family and loved ones if they would ask for that, a recommendation. And sometimes we have a rapport and a relationship with the family that allows us maybe to even recommend that if we can understand that their grief would be extreme and maybe even prolonged. And we need to also honor the patients and the family's decisions about the end-of-life care. So this certainly includes comfort. Patients wish for that and families wish for that, probably, to be honest, more than anything else. So that's a huge place where we can be an advocate for our patients and keeping them comfortable, because the outcome is going to be that they, their life here ends. And so we need to, that is our responsibility, to make sure that we're honoring their wishes about the end-of-life care. Comfort, spiritual care, whatever it is, we need to facilitate those things whenever it is possible. Okay, let's do a quick quiz. The nurse is preparing to assess a 1-year-old client for signs of discomfort. When conducting the assessment, which action by the nurse is the most appropriate? Is it A, asking the client to rate the pain on a scale of 0 to 10 during the assessment process? Is it B, asking the parent to hold the client in the lap during the assessment process? C, reading a book to the client during the assessment process? Or D, recommending that the parent leave the room during the assessment process? And the answer is B. Children may be fearful of physical assessment. To promote comfort, allow the child to sit on the parent or guardian's lap during the assessment process rather than asking the parent to leave the room. A numeric pain scale is not appropriate until the client is older. A FACES scale would be better. Reading a book during the assessment process is not age appropriate. So just to address quickly the FACES pain scale. It's faces that a child could easily recognize. They're kind of like stick figure faces. So it would be like a smiley face, right? That the patient could indicate is someone's happy. So, they're happy right now. They're not having pain. Could be a sad face where they're not feeling well. They're sad right now. Also, could be tears. So yes, it's very painful, and I'm crying, like that face is crying. So that's the FACES scale for children. Okay, here's a test your knowledge. The nurse is caring for a client who has suffered a massive cerebral hemorrhage and is not expected to survive. The client's mother indicates the client is Catholic. Which intervention is most appropriate? Is it A, if the nurse is not Catholic, then finding a Catholic nurse to continue care for the client is necessary? B, the nurse should contact a priest and ask him what must be done for the client. C, the nurse should assume the client's desires based on the nurse's existing understanding of the Catholic faith. Or D, the nurse should ask the client or the client's family what they want in terms of religious rituals. The answer is D. Cultural and religious beliefs and traditions are often of paramount importance for end-of-life clients and their families. Nurses should work to facilitate requests to every extent possible. Contacting a priest may be necessary for the client to receive the anointing of the sick, but the nurse should follow the client's or family's request in this matter. The nurse doesn't need to find a Catholic nurse to continue care and should not simply assume what the client wants in this regard.